All right, we're going to get started, everyone. And Donna and I will try our best to answer your questions regarding, getting into Zoom or some of the behind the scenes questions as best we can after we get started. I think you all can see the presentation, so I'm seeing your names as well. So it's equaling the number that I see at the bottom, so no worries. Welcome, everybody. We're so happy to have you. My name is Lori Kehoe. I am a member of the outreach team at SunCloud. I'm joined here today with my outreach colleague, Donna Bartlett. SunCloud Health provides integrated, nuanced treatment with residential PHP, IOP services for adults and adolescents with a focus on treating the whole person. Our locations are in Northbrook, Lincoln Park, Naperville, and our adolescent residential program is located in Matson, Illinois. If you are interested in updates about our program and services, Donna and I would be happy to meet with you, and we will be following up with each one of you after today's presentation. And our contact information is in the final slide. For today's CE credit, you will receive an email including the quiz and the survey, so please complete these to receive your CE certificate for today. You should expect to receive that within 7 days of filling out the survey and returning it to us. You will also receive a copy of today's PowerPoint in the email, along with a link to leave us a Google review. That's important for us and important to us because we value your confidence in SunCloud, and it also helps our community make informed decisions about where they want to receive care. So we would really greatly appreciate a Google review. Also, we have 2 more CEs this series, so be sure to sign up for the March and April CE. And we have the links to that available at the end of the PowerPoint. I'm really, really excited to share our presenter today, Kimi Simms. She is a licensed clinical social worker. She runs her own practice. She works primarily with adults and couples. However, her past experience has been not only in outpatient therapy since 2019, but prior she worked at the Nationwide Children's Hospital as an acute crisis response for children. Kimi has also had experience working in inpatient hospitalization for adults and community-based therapy for adolescents. Kimi loves reading, traveling, going to Cubs games, woohoo, with her husband, and hanging out with her fur babies. Kim is a trusted resource and a SunCloud Health community partner, and we are delighted and honored to have her share her expertise with us today. Welcome, Kimi.
Thanks so much, Lori. Really appreciate it. So good to be with all of you. So we have a lot of information to get through, and Lori's going to be collecting your questions, and I hope to provide a little bit of time at the end, but also very open to connecting with everyone via email or coordination calls, even setting up a little bit of a meetup if you're interested in learning more. One of the biggest things that I'm going to be recommending are a lot of really beautiful evidence-based practice books in particular, just to continue to support you as a clinician in addition to supporting our clients. So we're going to just jump right in. All right. So trauma-informed care for reclaiming your relationship with you. The reason why I wanted to kind of start off with talking about trauma-informed care is because we're all in different platforms. It sounds like we have people who are doing private practice, people who are probably working in hospitals, schools, etc. So really just starting off to set the tone for trauma-informed care, what that is, and then getting into some of the evidence-based practices for actual, implementation of caring for those who have trauma in their history or currently in their lives. This is a little bit about me. I'll also have this slide at the end. If you want to scan that QR code, that'll give you all of my contact information, ways to connect with me. In my practice, I actually work a lot with clinicians, and I kind of wanted to start off with just that as well. As we're doing our work with trauma it's really, really important that we are also taking care of ourselves. And I know that so often we get burnt out. There's a lot that is happening in the world in the here and now. So if you need any type of support, or if you are also looking for any type of your own trauma work, please reach out, okay? All right, so jumping straight into some of these learning objectives, talking about the importance of an integrative approach to trauma reprocessing. So I am not going to be one of those people that's like, I am EMDR only, or I am CBT only. I think it's so important, as we are especially working with people with such complex trauma, that we really educate ourselves of all of the beautiful evidence-based practices and research that's out there. So again, this is going to be kind of a high-level introduction to a lot of these approaches. And I hope it's insightful to help you to have a little bit of a broadened scope of what you can do with complex PTSD with your clients. The other piece is learning about psychoeducation. I love the fact that as therapists, we have the opportunity to be teachers. Teaching our clients what's happening in their nervous system, teaching our clients what's happening in their brains on a layman's terms, so that they can really understand what's happening and really, starting to have that reconnection with themselves as a holistic person. The other part is that we really want to make sure that our clients understand that, this is not a linear process. Trauma reprocessing is kind of all over the place. And so I'm going to provide some really good kind of mantras to help with clients when they are feeling that internal chaos, or they're feeling external chaos in their lives, to remember that healing is not a linear process, nor is it an end result. We are constantly trying to keep up our healing process throughout our life and throughout our development. A lot of times I have clients who come in and they want to start off right away with, I want to have better relationships with other people, which is lovely and wonderful. And that starts with really having a better relationship with yourself. Okay, so just kind of starting off, this is something that I invite all of my clients to do when we're starting off our sessions, is just noticing, observing, and acknowledging what is actually coming up for you. There's going to be a lot of information that I share, and it's most important for you to check in with that insight orientation and acknowledge your intuition of what is really standing out to you as we're going through this process. So insight orientation and intuition, this is one thing that I teach really upfront with clients, is learning how to reclaim your trust in your intuition and your insight, your anxiety. So often with CPTSD, clients really only know how to take note from their anxiety due to their trauma responses. And we'll get into that a little bit more. So first off, I wanted to start off with some reflection questions. If you met yourself on the street as a clinician, as a person, as a whole, human being, would you want to be friends with yourself? Why yes? Why no? Do you ever find yourself giving great advice to others, but feel your internal rules are a little different for yourself? Do you feel out of place within your family of origin dynamics? If so, do you also feel authenticity has to be sacrificed for attachment? So again, just notice what kind of comes up for you, and we'll circle back to some of that. What stands out to you, and stay curious. So often our clients come in with such a heavy shame cycle and such a strong inner critic. So we really want to help clients to better understand the difference between being critical about yourself or being curious about yourself. So that theme will come up a lot throughout this presentation as well. Hypocrisy and countertransference. We are still humans. Sometimes our clients, our students, our patients, etc., forget that we are also human beings who have lives, who have our own attachments, who have our own histories, and have our own mental health circumstances. So I would just ask, as we are really working with our clients who have some trauma or family-based trauma, we should not be asking our clients to do anything that we would not be doing for ourselves within reason. That doesn't mean that everybody needs EMDR, but that willingness to make sure that you are doing what you're asking your clients to do. And then again, taking care of yourself. Going back to some of those questions, are the rules different for you than the rules that you would give to another person? Being okay with being fired. Okay, whenever I start an assessment or a first intake, I almost always tell a new client this: I'm not the right fit for everyone. There are so many beautiful, wonderful clinicians in this world. I am not in this world that I think that I am the only one. So if we start to work together, give me a couple of sessions. Let's see if we can build some of that stronger attachment and that secure attachment within that therapeutic rapport. And if we get down the road and you're like, oh my gosh, meeting with Kimmy is the worst. I'm dreading it. This is horrible. Fire me, but tell me. And so we can help you to find a clinician that meets your needs. Be okay with being fired. Our clients so often have a power differential where they feel like they have no voice. And this is a space that we do not want to be re-traumatizing to them. So starting off with that assessment of saying, I'm okay with being fired. This is not about me. This is about us and our work together, but this is mostly about you. Okay. Scope of practice. I know that we're, doing some beautiful stuff with eating disorders this week. I am not an eating disorder specialist, but there are so many people in this world that are. So if you are doing an assessment with a client and you recognize that there's going to be some barriers for you to really start doing some of this trauma work, for example, substance abuse. I also am not a substance use counselor or a substance abuse counselor, but there are so many wonderful people in this world who do that work. So just really stay in your scope of practice and don't be afraid to tell them, hey, sounds like your first need is X, Y, or Z. Once you get X, Y, and Z, a little bit more regulated, come back to me, and then we can really start to do this trauma work. Okay. Window of tolerance. So this is something I'm also going to invite you to do as we're going through this presentation. Staying within that window of tolerance, notice if there's any shifts in your nervous system. Are you getting heightened and feeling a little bit of that heart palpitation and getting into a little bit of that anxiety, into hyper arousal? Or are you dropping and dipping into some depressed mood or feeling some sadness, some complicated grief and loss and feeling more internalized, or even getting into some disassociation? We really want to work with our clients within that window of tolerance. And as we stay in that window of tolerance and challenge just a little bit with psychoeducation, intervention, we really hope that window of tolerance really expands. Yet again, that starts with us also recognizing how to notice our window of tolerance. And then that will help us to better educate our clients on how for them to notice that as well. Okay. Mantras. I said that this kind of comes up a lot. Options and choices. So often in our trauma care, clients have hyper focus and they really can only see just that zoomed in hyper focus on one thing. We want them to expand options and choices, to empower them that there are different options and choices in front of them. And we're seeking progress, not perfection. And again, back to that linear process. It's kind of all over the place. We might take 10 steps forward and feel really great progress. And then we might have a triggering event and feel like we get a little push back into some regressive states. That's okay. We just want to really focus on progress and allowing our clients to define what progress looks like for them. Reclaiming and exposure therapy. Whew. Just meeting with us as clinicians, as a counselor, as a doctor, a psychiatrist, etc. That is exposure therapy for so many of our clients who have complex PTSD. Choosing to trust a person of power is exposure therapy for them. When we're asking them to go out and to change their options and choices or see their options and choices, that's exposure therapy. Anytime they're choosing to have an attachment with someone, that is exposure therapy. And more likely than not, their nervous system is already at a 10 out of 10 just by trying to connect with another human being. So really comforting our clients that constantly they're in exposure therapy. And that's a really difficult way to live life. And so again, providing some of that compassionate response of this is hard work and we're going to meet you where you are, with a hope that we can reclaim some of these relationships, especially with our relationship with ourselves. All right, so let's get into the psychoeducation and evidence-based practices. What is trauma-informed care? So first, it shifts the focus from what's wrong with you to what happened to you. When I was working at Nationwide Children's Hospital, we would go around and we would actually provide education on what trauma-informed care was to hospital staff, because we can't necessarily expect them to understand what trauma-informed care is because they have a different scope of practice. They are doing the medical side, which we absolutely need, especially as clinicians, like medication management, great doctors, but trauma-informed care is so important. So what we would teach first and foremost is we're going to assume and this is a good assumption, we are going to assume that everyone who walks into this hospital has some form of trauma. And we are going to treat them as if they have trauma. So we're not going to touch them. We're going to make sure that we try to do our best to ask for consent. Really just thinking about that human being, that they have that little bubble, and more than likely they're coming into this hospital with a big trauma history. So not what's wrong with you, but let's talk about what actually happened to you and how that impacts your thoughts, your feelings, and your interactions with yourself and your interactions with others. So trauma-informed care realizes the widespread of trauma, understanding the paths of recovery, recognizing the signs and the symptoms of traumas in patients, families, and staff. This also goes to show, noticing these things in your colleagues as well. Trauma-informed care, assuming that we all have some form of trauma in our history. We may not be meeting the criteria for certain, diagnoses, but more than likely all of us have some form of trauma in our past. Integrating knowledge about trauma into policies, procedures, and practices. So I'm in private practice, but this is really important for those in especially like school social work, working with families, working with parents, working with adolescents, that we really make sure that our policies, procedures, and our practices do inform, take into consideration trauma-informed care. And it's kind of up to us to advocate for that, because we're the experts there. And we really should advocate and be the voice of our clients, our students, our patients. Actively avoiding re-traumatization. Again, going back to that assumption that everybody has a trauma history and we do not want to re-traumatize. Does it happen sometimes? Yes. And we hope to avoid it the most that we possibly can. Creating safety, trustworthiness, transparency, peer support, collaboration, and empowerment. And, being decent human beings, okay? What is trauma? So trauma is any disturbing experience that results in a significant fear, helplessness, disassociation, confusion, or disruptive feelings intense enough to have a long-lasting negative effect on a person's attitudes, behaviors, and other aspects of functioning. Woo! That definition alone we could spend so much time on. But again, any disturbing experience that's resulting in significant feelings, states, and impacts our attitudes and our behaviors towards ourselves and towards others and our functioning. 7 core traumas, big T traumas. We're talking about assaults, wars, etc. And I forgot to say this in regards to, we might be talking about some triggering experiences. So again, back to this taking care of yourself. If anything is coming up in this presentation where you're feeling like you're getting outside that window of tolerance, make sure to take care of yourself. Shake it off, go get a drink, take a break, take a pause, and then come back when you're feeling like you're ready to engage again, okay? You're going to get all these slides, so you're going to be able to review over this, but again, take care of yourself through this process. Little T traumas, job loss, unexpected moves, difficult relationships, chronic trauma, long-lasting experiences or responses, complex trauma, repeated relationship distress from childhood. Insidious trauma, daily marginalized groups. This is where we talk about intersectionality, microaggressions, cultural competency, and understanding that, all of our clients and our patients are coming from very, very different backgrounds. So that insidious trauma, really important. Secondary trauma, which for us, we also might want to, take a little bit of note on how we are doing with our secondary trauma as clinicians when we are in that space hour after hour after hour, hearing these stories, feeling those stories with our clients. So vicarious trauma, exposure to other people's trauma. And then integrational trauma, passed down through those families. This is intergenerations, generational trauma. The most important thing I typically call trauma. I don't get to define that, but I help clients to understand the definition of that. But big T versus little t traumas. What might be a little t trauma to someone else could be a big T trauma to you, and that's okay. We're all affected differently by our unique experiences. Research also suggests that a lot of little t traumas, going back to this complex trauma of mistreatment, of lack of attachment, lack of healthy, emotional processing with parent figures and attachment figures, that experience day after day with no adaptive processing, meaning no repair, no comfort, no compassion from those attachment figures, we actually recognize that some of our trauma responses can be as significant as a big T trauma. So again, what might be a little T trauma to someone else could be a big T trauma to you, and that's okay. Part of this power of reclaiming is about noticing what is trauma and how you define that and how you narrate that, which we'll get into a little bit. Okay, what is attachment trauma? When our caregivers are unable to meet our emotional needs as children, attachment trauma occurs. Attachment trauma is a form of relationship trauma involving a severe disruption in the bond between a caregiver and their child. So, a disruption in the bond between a caregiver and their child. This can also include parentification, when attachment figures aren't able to actually meet basic needs, and children take on the role of parents and comforting their parents and providing the emotional support that they really should be getting as the child. And so some of the work that I do is really recognizing, like, you were the kiddo, you were the child in this circumstance. And again, it's not about blaming attachment figures, it's about learning from this attachment trauma so we can really build up to the future of attachment that we would like to have in our adulthood and in our chosen relationships. Okay, overt and covert attachment trauma. So I think a lot of people would not debate about overt, causes of trauma when there's fear, abuse, coercion, neglect, a death of a close family member, witnessing domestic violence, actually, having to be a protector of a parent who is in a domestically violent situation, a caregiver who's struggling with substance abuse and choosing a substance over their child, and the absence of a caregiver, or again, some of the divorce where you have two attachment figures or multiple attachment figures, and now you're kind of splitting your time. A lot of the education that I do with my clients is more about these, covert causes of trauma where, they don't know anything different. That's the life that they grew up in. And so it takes us to recognize, like, to tell them, that's maybe not a typical experience. And X, Y, or Z is why that's not a typical experience. And I try to stay away from the word normal because I think that's very triggering for many of us. Because what is normal? But a typical experience of a healthy, secure attachment, having attachment figures who are actually there to meet your needs or to help you through a stressful, hard process. Okay. So this is more of a general lack of affection of a caregiver towards their child, where maybe they are prioritizing themselves over, really attaching to their child. When a caregiver is physically or emotionally unavailable, where maybe there's lack of, physical touch or hugs or comfort or care or hand-holding. Sometimes those experiences of postpartum difficulties and postpartum depression really cause some of these covert lack of attachment for kiddos when they are really, really young and needing that love. But a parent is having such a hard time with their own mental health that they are just not able to give that to their child at that time. Poor boundaries within the home, including back to this parentification. I see parentification all the time on my caseload where, clients just really have never experienced what it's like to relax, to have fun anymore, to play, because they've been in this role of providing, parenting to their parents. When a caregiver manipulates or attempts to control their child with withdrawing affection and evoking shame and guilt. We're going to talk a lot about shame and guilt. So adaptive processing. I'm going to talk a lot about learning how to respond to our triggers. Unfortunately, this is not a fun thing for clients to recognize, that triggers are never going to go away. We have to live in this world. Triggers are all around us. It's about choosing our response and empowering ourselves to recognize that just because we're triggered doesn't mean we have to react or allow impulse to take over or trauma response to take over. We can choose responses, but that takes a lot of getting to know ourselves, not avoiding recognizing that we have triggers, and really starting to recognize what those triggers are, which again, exposure therapy, okay? Circle backs and repair. Adaptive processing doesn't mean we don't have traumatic experiences happen. For example, a parent yells at a child out of agitation, irritation, they're stressed, they have this big work project, and their child comes and they're like, mom, 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 dad, 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 dad. And they turn to them and they yell, like, you need to go away. You need to go away. I don't have time for you. You are a problem. without a circle back to come back as a parent to that child, they may internalize you are a problem and come into development thinking that they are a problem. And that's one of their negative core beliefs that they have about themselves, because a parent, unfortunately, again, due to many circumstances, I'm sure we're going to have compassion and understanding that human beings are human beings, yet that's an inappropriate way to treat a child without coming back and saying, hey, I'm so sorry, sweetie. I was really stressed at work. That is my stress. And I'm so sorry for calling you X, Y, or Z. I hope you know that that's really not true and that I love you and that you're so sweet. And I'm sorry that I reacted in that way. Circle backs, repair, repairing conflict, repairing hurt is one of the best indicators for building secure attachment is repair. We're not expecting perfection. We just have to learn how to repair these relationships. Okay. Ambiguous and complicated grief and loss. This is just something I think that we need to recognize, that not all loss looks the same. Many of our clients are having a hard time with understanding that they don't have a parent that maybe meets all of their needs, that maybe they don't have a parent who really sees them or feels understood by that parent. That creates that ambiguous loss of what a parent could be for them and what a parent wasn't for them. Okay, so that doesn't mean that this parent is actually not there. It could be that ambiguous loss because a parent was choosing substances over their child. They were choosing an abusive partner over protection of their child. Ambiguous loss, okay? What is complex trauma? Complex trauma tends to stem from relationships and is often linked to difficult childhood experiences. I don't really try to get too much into this is the difference and that is the difference. Yet, complex trauma versus complex PTSD, there's going to be a lot of people who debate this, but in general, I just think that complex trauma is complex trauma, and we don't have to get too much into the nitty gritty details of are you this or are you that? No, trauma. Let's just talk about the trauma, okay? Let's not get too lost in some of these diagnoses, because remember, the DSM is lovely. It does not take into account all of this experience of trauma-informed care and the need for meeting the needs of trauma in general, okay? It's a great access to symptoms and understanding some of these general diagnoses, but just remember, meet that client where they are, okay? What is CPTSD? It's a mental health condition which results from experiencing chronic trauma. So I'm going to skip ahead. Again, some of this CPTSD, these are things that you can find on some of these websites. You can go back and review some of these symptoms, but we've kind of talked about these symptoms through some of these previous slides. So I'm not going to go too much into, again, these symptoms, but again, your clients are going to tell you what is going on for them and what their symptoms of CPTSD are. We just have to listen and create a space and an environment where there's not going to be shaming for really talking through what's going on in their internal world for them. Suicidal ideation, we will talk about a little bit throughout this. So again, just kind of giving a little bit of a highlight that we will talk about assessing for suicidal ideation with CPTSD. So just putting that out there as well, okay? Survival mode, fight, flight, freeze, and fawn mode. Just keeping that in mind that a lot of our trauma responses are going into survival mode tendencies, okay? So our first lovely book, Pete Walker, 5 Troublesome Features of CPTSD. This book is full of triggers for clients. If you are recommending that they read this book, make sure you are giving them the insight of window of tolerance. If there's an example in this book that feels too overwhelming to you, you don't have to read the case examples. That's more for us as clinicians. Skip to the information about learning about what's happening in your nervous system. One of the biggest things that I find clients finding comfort in once they recognize what's going on are emotional flashbacks. So emotional flashbacks, sudden and often prolonged regressions, again, those amygdala hijacking back into those, survival modes, to the frightening and abandoning feeling states of childhood. Fear, grief, depression, rage, abandonment, alienation, shame, guilt, survival modes, etc. Okay? So simply put, again, in layman's terms, if you're having a reaction to something and the emotion doesn't match the circumstance, you're likely in some type of an emotional flashback and in a regressive state. So we, again, teach our clients how to recognize the emotional flashbacks. When we know those, then we're able to identify them and give ourselves some of that compassionate response. Okay, whew, I'm in a regressive state. Now I'm going to not be in a reactivity state. I'm going to be in a responsive state, knowing that I'm probably having an emotional flashback because my partner just put the groceries away and now I'm in a rage. Okay, maybe that emotional response isn't quite, appropriate to the circumstance. Toxic shame. Ooh, shame-informed therapy, we're going to get into a little bit, but toxic shame is such a scary internal world to live in. Everything I do, I am bad, I am wrong, into this self-abandonment. That's why we want to reclaim the relationship with ourselves. We no longer want to lose ourselves in being only a human in interactions with other people. We want to make sure that we're not abandoning all of our parts that also need something from us. Inner critic, we're going to talk a little bit about that, and a lot of social anxiety. Back to exposure therapy. All relationships, when individuals who have CPTSD, that's an exposure therapy. They're going to have some of that social anxiety. The guilt, shame, blame game. Guilt is going to come up all the time. Guilt is an emotion. What is difficult with CPTSD is many people think that because they feel guilty, they really did something wrong, versus we need to teach them that guilt is an emotional experience. We are going to feel guilty sometimes. And sometimes we've been trained and conditioned from our attachment trauma to feel guilty about things that really actually we didn't do anything wrong. Our brain and our nervous system is just trained and conditioned to go to that feeling state. And the same thing with shame and blame. All right, one foot in the past with one foot in the present while looking towards that brighter future. This is one of those EMDR, kind of scopes. I always like to help clients to recognize, again, those regressive states. We're going to keep one foot in that past, but we're always going to keep one foot in this present. How is that impacting you in the here and now? And how can we help those past parts of you, and maybe even those current parts of you, to look towards that brighter future, to learn from those experiences within your circle of control, and we'll get into that as well, working towards that brighter future. Okay, so EMDR, eye movement desensitization and reprocessing therapy. I have a lot of clients who come in and they're like, I want to do EMDR tomorrow. I want to start doing bilateral stimulation tomorrow. That's not how I approach EMDR. So I like to tell everyone that EMDR is what we're doing with all of these other evidence-based practices with phase 1 of 8, history taking and preparation. We are doing EMDR. We're just not doing the bilateral stimulation, which we will get into a little bit later. All right, shame-informed therapy, Patty Ashley. If you're looking for a really beautiful workbook in regards to clients just really not able to get out of that shame-blame game, this is incredible. I would encourage any clinician to just get a copy of this, read through, again, her integrative approach for shame-informed therapy. It's lovely, wonderful. What is self-compassion? I almost always start working with clients of, we are going to try to build self-compassion. Having compassion for oneself is really no different than having compassion for others. But this is, again, back to those internal rules that maybe we just don't feel worthy of some of that compassion. But compassion isn't that we're going to love ourselves or that we're embracing everything about ourselves. Compassion is noticing that there's suffering and responding to it in that internal way. Allowing ourselves to note, hey, there is some suffering there, and I want to be with myself in that process of taking care of myself and learning what I need. So, Dr. Neff, thinking about a time when you felt compassion for a close friend who was suffering. First, to experience compassion, you have to actually notice that your friend is struggling or feeling badly about themselves. You have to notice first. So, again, back to that invitation to start noticing, observing, and recognizing. These are a couple of myths about self-compassion. I hear these a lot from clients, but it's not indulgent. It's about a response system, noticing that they're suffering and choosing to respond with compassion versus criticism. So I'm going to go through this again a little bit quick because I'm looking at the time. So self-compassion is so vitally important to start building a healthier response to the criticism. Okay, that inner critic. If we just change the tone, why did you do that? Why are you acting like that? How could you choose to respond like that? That inner critic, if we just change that tone to, why did you do that? That seems really interesting. That was an interesting response, like a really interesting reaction. Why did you do that? That's going to be, again, far more insight oriented than listening to that inner critic. Those questions could be really important, but we can change the tone to compassion and curiosity and learn from that part of us, that inner critic, of maybe sitting and actually answering those questions in compassion and curiosity. Perfectly hidden depression. So this is where the assessment for suicide comes in, when we have clients who come in and they're presenting very, I function, I get things done, my to-do list is how I define myself, I just do, 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 do. But what's really going on deep down is this: I expect myself to be perfect, and this is how I've learned to cope with my trauma. Yet deep down, if I was really to recognize, I am feeling critical, shaming. I feel this fear, anger, loss, grief. This is a different way to view depression. We see this all the time. Well, I see this all the time within my clients. We're like, I'm not depressed. I'm not laying in my bed all the time. And they start to talk about, some of the DSM or what's out there in media. And I say, depression looks different for other people, especially when you add in CPTSD. So these are some of the symptoms that Margaret Rutherford goes over within perfectly hidden depression. Again, depression doesn't all look the same, especially if you add in trauma. So if you are seeing that clients are having some depression, depressed mood, but it just doesn't look the textbook, they're likely having their own version of depression mixed in with their trauma response. So again, taking an opportunity to see some of these diagnoses, see the DSM as, again, a guide, but not as an end all be all. Okay. Suicidal ideation. One thing she really found in her research is that when she would do her assessments and ask about history of suicide, it would be a quick, no history. And she recognized that the question for perfectly hidden depression was more, if you ever did have suicidal ideation, would you ever tell me? Would you ever tell someone? And oftentimes we recognize that we have to ask the right questions in order to get the answers that are really, again, authentic and into that deeper core. So she goes into more really beautiful assessments, some reflections. So if this feels like something would be beneficial to some of your more perfectionist clients, your high functioning clients that are also having a lot of trauma response, very important literature to review. All right, we're going to get into some CBT. I'm assuming that most of you have been introduced to CBT, but just in case, these are just a couple of overviews at a high level. Requires a sound therapeutic relationship, a lot of education, includes action plans, action orientation, emphasizing the present. Again, that one foot in the present, so important to tell us about how our past is haunting the present while looking towards that brighter future. And a lot of recognizing thinking, feeling, and how that impacts our behavior. So again, this CBT triangle probably isn't too, I'm sure many of you have seen this, but where I find that this is really important is in these thinking errors, thinking traps, cognitive distortions, linking back to some of these negative core beliefs, again, back to exploration of what is your thinking really telling you? So this is an example of some of these thinking traps. And this empowers clients to recognize, just because your brain is telling you worst case scenario is going to happen, we'll respond with compassion. But is it really going to happen? And if that worst case scenario, that catastrophized version of your thought does happen, how are you going to cope with that? What's the worst case scenario? And let's talk about how we cope with that. All the way to the best case scenario. Where do we, can we handle all of that? So long and short, recognizing and labeling thinking traps for CPTSD, vital, so that clients feel empowered to challenge those thoughts and recognize, oh my gosh, that's my anxiety really speaking to me. It's giving me this overgeneralization of everyone doesn't like me. Okay, based on what? Oh, I don't know. Well, that sounds like a thinking trap. That doesn't sound like that's actually true. It just sounds like your brain is telling you that that is true. Mind reading happens all the time. Self-fulfilling prophecy happens all the time. So if you are not familiar with some of these cognitive distortions, really encourage you to do some education for yourself so you can help your clients to feel empowered that just because they think it doesn't mean it's true. Okay. And then we want to activate, again, a response to those triggers, challenging some of these cognitive distortions with compassion, understanding, and some of these other beautiful modalities that we'll get into. Circle of control. Your actions, your responses. That's it. That's all we can control. So often I see clients wanting to jump into, well, I want to change this other person's behavior. Well, sorry. What's within your circle of control? Let's just stay there. Let's empower this part of you of you have options and choices. What are those options and choices within your chosen behaviors, your chosen responses to what's going on around you? Okay. Trauma focused CBT. This is so excellent for both kiddos and adults, and it helps us to reclaim a lot of our past experiences. So what I do with trauma focused CBT and narrative therapy a lot, so I'm going to just jump to this one. Remember, this is not about blaming our attachment figures. This is about learning from our experiences so that we can have a better understanding of where we're coming from and take care of our younger parts, which we'll get into a little bit of IFS soon. But really recognizing this is finding your voice about what happened to you, back to that trauma informed care. What happened to you and why are these things happening in the here and now? The more that we can have a trauma history, I often ask clients to think about this in terms of let's create some type of a table of contents for your trauma history. What chapters do you remember? And let's really, again, get that left brain going and that right brain going at the same time, creating a table of contents for your chapters of history and your trauma chapters, okay? So this helps clients to stay really focused in the here and now and recognize they're learning from their trauma chapters and bringing that insight into the present moment, looking towards that brighter future, okay? From trigger to tranquil, I kind of went over this a little bit, but Dr. Campbell talks a lot about use of self-compassion, some tangible reflections. If you're looking for some beautiful interventions or a little book club, I use this one with couples quite often. We'll do a little book club in between our couples counseling sessions, and we'll just talk about, how to recognize the triggers that are coming up for you and transform relationships and conflict and some of those regressive states that are really impacting the relationship dynamic in the here and now. Again, triggers are not going to go away. We can learn how to respond differently versus react to those triggers and those trauma triggers in particular. Adult children of emotionally immature parents. Whew, this one is a small book full of so many beautiful nuggets. So, the thing that stands out to me the most is when clients still want to have relationships with their attachment figures. We talk about the difference between seeking relationship with an attachment figure that has proved to not necessarily be somebody that can have a secure attachment, meaning being reliant on them, meeting emotional needs, we talk about having a related relationship with them, meaning we just talk about certain topics with each other. We don't get into the emotional states because, again, back to your circle of control, if parents aren't willing to do the work, you have options and choices, and you might have to radically accept, which we'll get into, that your parent isn't going to change until they want to. So how do you feel about that, and what do you want to do with that? Okay. This one, again, such a great psychoeducation for ourselves, also for our clients, that they're really, really working on becoming an adult that has emotional intelligence, but was not necessarily raised by a parent who was able to teach them those things. Internal family systems. Okay, IFS. So there are a lot of different forms of IFS, in my opinion. I do a more integrative approach, back to that trauma-focused narrative or cognitive behavioral therapy, trauma-focused cognitive behavioral therapy. I try to help clients to see, again, in their table of contents, in their trauma narrative, in their history, in their chapters of trauma, what are the characters that are also developed throughout that trauma narrative? And that's where internal family systems really comes into play, of recognizing that there are different parts of us that all have different needs. Sometimes clients will start off with noticing their emotional states and then recognize that's a full part of them that gets activated. So I want you guys to think in terms of like inside out. Who's at the control panel? Which part of you is in the driver's seat is often what I talk about with clients. Starting to recognize that within their internal world and getting to know those parts versus rejecting those parts. So many parts of us are holding on to those traumas that we have to get permission from those parts that we really want to reject or avoid. those are probably the parts of us that need the most compassion, the most understanding, and the most connectivity. So I'm going to show just a little introduction. It's like probably just the 2 minutes. This video is fantastic. It's like I think almost like 18, 19 minutes, but just as an introduction, she just does a beautiful job of introducing internal family systems. So we're going to just watch this for a moment.
Right under our distressing ways of being, there's a version of us that has amazing capacity and care. Unlocking that capacity and care and using it in our healing work is what IFS therapy is all about. One thing that is amazing and very unique about internal family systems therapy, or IFS, is that it teaches us as the client how to become our own therapist in a way, our own healer. They might use the term leader. It does so through putting us in contact with a somewhat hidden potential self, what you might think of as our best self or our deeper self, right from the beginning, without taking years to develop. Getting in touch with that deeper part of ourselves is so invaluable and is an amazing part of the IFS model. In other words, it doesn't just undo a disorder and help us come function at a baseline. It goes beyond that to this really resource state. This state, and now I'm going to sound a bit out there, but I think of it as like an enlightened version of ourselves. Now, if you're thinking, believe me, I'm not an enlightened person. I drink too much, I have a really hot temper, I'm really insecure. That's just who I really am. That's the only me I've ever known. Well, it's not like in IFS we would say, no, all those problematic behaviors are just an illusion. In fact, we really start with direct focus upon the parts of ourselves that we struggle with. The difference is we approach those parts as just that, as parts, not the whole. But before we really explore why it is absolutely more accurate to think in terms of parts, I just want to start with appreciating why it is also more respectful. I teach my students to think in terms of parts, even if they never use parts language with their clients. Like I'll tell them, please don't say, my client is a drinker or a cutter. No, they are not a drinker. They are a complex human being who has a part of them that feels compelled to drink. A part of them. That part is not the totality of their selfhood or define who they are. But what does this concept of parts have to do with that enlightened version of ourselves I was mentioning? Well, in IFS, when we can understand these aspects of our identity that we struggle with, the moment we realize they are just one facet of ourselves, it allows us to step back in a way and to be able to finally actually see this part more clearly, and more importantly, to approach it with compassion and curiosity. That's what we're going to talk about in these videos.
Okay, just such an amazing introduction to, a little bit more of the way that I approach internal family systems. Now, there are a lot of, certified IFS therapists that do really intensive internal family systems work where they're going to get into labeling these parts a very specific way and in a very specific manner. For me, it's more of this type of language. Well, okay, no, you're not all or nothing. You are a complex human being. And we want to make sure that we are attuning ourselves to all of these different parts of us. She used that example of there's a part of you that is compelled to drink. Okay, well, then we engage in curiosity, compassion, and understanding with that part instead of rejecting that part or labeling ourselves all or nothing. Okay, well, when that part of you gets activated that really wants to drink, what's the deeper concern that's driving that desire? Why do you feel the need to drink? Oh, because I feel intense loneliness. And when I drink, I feel a little less lonely. Okay, so there's another part of you that feels immense loneliness. Let's talk about some coping mechanisms to make that part of you feel like you could be best friends with that part and not feel so alone. So, again, back to that first initial reflection question of would you meet yourself on the street and would you be friends with yourself? Why or why not? We are with ourselves our entire lives. We might as well create a really, really healthy relationship with ourselves because we're going to be with us for the foreseeable. So, why wouldn't we want to create a little bit of a healthier relationship within those parts? So, again, this video, fantastic. You should have a link to it when the slides go out. I would really encourage if there was a part of you that was like, ooh, this seems really interesting. please finish that video. Lovely, beautiful. She just does a great job of, again, that psychoeducation of how to utilize this, especially as clinicians, and then help you to teach your clients how to start identifying these things. Emotional states also come up a lot in this, where clients avoid certain feelings. Clients are okay with feeling anger, and that part of them is activated all the time and is in the driver's seat and taking over the steering wheel and creating so much chaos all the time and driving their decision making. Again, reaction versus responsiveness. When we really start to explore the anger part, we might actually say, okay, well, what else is there? What's activating the anger? Well, I feel misunderstood all the time. Okay, well, then there's a part of you that's feeling really misunderstood. Can we get some permission from that part of you to explore a little bit more about what's going on that deeper level with that misunderstanding? With emotions as well, IFS is a beautiful way to start to allow those parts of you to have a seat at the table, to invite those parts of those feeling states into the room. And recognizing that, if you're angry versus hurt, your response to those emotions are going to be different. You're going to take care of a child who's angry differently. You're going to take care of an adult who's angry differently than somebody who's embarrassed, feeling insecure, or feeling hurt. So again, that back to that CBT, emotion identification, emotional experience of, again, that nervous system response, recognizing the differences in those emotional feeling states, really important. And IFS helps to have a little bit more of that creativity. You can get into using art therapy, sand tray therapy for internal family systems, of getting to know these parts of you. What do they look like? Are they gendered? Are they an animal? Is this part of you a version of one of your attachment figures, but now has become a big scary monster? Again, this gives you more attunement to these parts of you to feel less afraid of connecting with them. So I'm looking at the time. I know I'm running a little bit low, so I'm going to just skip over a couple of these. Again, these are amazing. So just circle back. This Self-Therapy, such a beautiful book, an amazing book if you're wanting a little bit more self-exploration. And the self, meaning not doing therapy for yourself, but the sense of self, as she said, that part of you that's more enlightened. We want to get to more of that sense of self. All right, DBT. Okay, I'm going to skip over to dialectus. And language is so important instead of but. That can change the way that a client feels about themselves. It's not all or nothing. Adding an and. I feel like I'm the craziest person in the world, and I feel like I have such incredible ability and capability. Both of those can feel true. Again, back to the parts work, okay? We are complex humans. And language. Fast is something that I use all the time. Fairness, not over apologizing, sticking to your values exploration, again, so important. So DBT can be so helpful for action orientation, setting boundaries, distress tolerance, emotion regulation, and especially a wise mind balance, and willingness to open up versus willfulness of what you want to push away. Okay. Again, DBT, beautiful, wonderful. There's some really great tangible books out there on DBT. Fast, again, this is what I focus on quite a bit, of the self-respect and finding that part of you that can feel more self-respect and make more decisions. Again, responding in self-respect versus reacting to the trigger that's there. EMDR. Okay, BLS. Let's just jump into it. BLS is the eye movement therapy part of EMDR. It helps to do REM sleep, basically in a wakeful state where you're crossing that midline. Have you ever gone to sleep really, really stressed out, and then you get a really beautiful good night's sleep, and then you wake up the next day and you're like, that last night just felt really, really heavy, and this morning is not feeling so heavy. That is what we are trying to do with bilateral stimulation, okay? EMDR takes a lot of really intensive training process. And so, again, as a clinician, I am EMDR trained. And so if you have more questions about this, or how to get trained, or, the process as maybe a client yourself of interest in eye movement desensitization reprocessing, reach out to me, okay? All right, radical acceptance. This is where I want to end. Radical acceptance is the ability to accept situations that are outside of your control without judging them, which reduces the suffering that they cause. You can learn how to practice radical acceptance with accepting things for what they are and acknowledging your emotions without denying, avoiding, or ignoring the situation. it is what it is. And again, that dialectic, how do I feel about it? And what do I want to do moving forward? It's a very, very behavior activating radical acceptance. And that's a daily, hour by hour, minute by minute decision to radically accept circumstances and how you feel about it and what you would like to do with it going forward. Beautiful book, Radical Acceptance. If you're interested, Tara Brach is fantastic. A lot of her training comes from Buddhism and meditation. A fantastic read if you're looking for more education about radical acceptance and implementation of radical acceptance. And then books, 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 books. So I have tons of book recommendations. If you guys are looking for more, if there's a specific type of trigger or symptom that you're looking for, please reach out. I'm going to jump into thank you so much for participating. And again, these were such high levels, but I'm going to turn the time over to Lori. Thank you so much for your time. Appreciate everybody being here.
Wow, I'm getting much feedback that this is the best webinar that we have offered so far in the last 2 years that we've offered these free CEs. One of the things is that they'd love to have you come back and take a deeper dive. So hopefully we can talk about that. I do have a question, and friends, if you have a question you want to put in the chat, while you're doing that, I do have a question. If you could just explain the fawn mode in
Yeah.
trauma responses.
Absolutely. So fawn is, there's again some debate in the research of whether that's a survival mode. It absolutely is. So many clients come in with people pleasing tendencies. So I want you to think in terms of parts, that part of you that's willing to sacrifice your authenticity, your boundaries, your self-respect for the pleasing of another person. So that often happens when there's been abusive situations. But the fawn part is really like, okay, well, whatever you need. I want to be liked. I want to be cared for, quote unquote. So I'm not gonna push back. I'm just gonna give in to whatever is happening in this moment because that feels safer than standing in self-respect. So that happens often. That's a great question. Yeah.
And we're getting swarms of comments. Yes, please have her back. A longer training. You're a fantastic teacher, and you are, Kimmy.
Thank you.
We just so appreciate you, and we will have you back if you're willing. I just want to thank all the people, all of our friends that come every month to these presentations, and give us this type of feedback because we want to offer you, friends, the trainings that you need and desire, to edify your work. Be sure to sign up for our next two CEs. These links will also be in your follow-up email, so be sure to sign up for those. Oh wow, they are just flooding in, Kimmy. Thank you
Thank you
so
guys.
much. Thank you
Oh,
so
thank you
much.
guys so much for coming and taking care of all of your clients and yourselves. Just thank you for being here.
I think what's really special about this is that here you are now as a resource for all of these school social workers, these clinicians, these providers, and we can further together, join together and help one another. And that's something that you and I and Donna were talking about before the presentation started. We need each other, and here we are. We have you to help us and to grow from, and so thank you.
Thank you guys. And please reach out if you want any more, if you have some more questions or follow up. All my contact information's there. Love working with other clinicians. So I'm here as a resource. And Lori, Donna, Sal, Robert, thank you guys so much for all of your hard work behind the scenes. Really appreciate it. And thank you guys so much.
Thanks, Kimmy.
Thank
Happy
you.
Friday,
Thank
everyone.
you.
Yes.
Thank you. We'll see you next month. Take care, everybody.